Good morning, everyone. I'm Shelby Monier, Vice President of Patient Programs and Education here at Zero, the End of Prostate Cancer. I want to thank you very much for joining us today for a special discussion on PSMA PET imaging for prostate cancer. Today, during this discussion, we'll focus on PYLARIFY, which was approved by the FDA last year. And we're going to talk really about how it can provide more precise testing and better guide prostate cancer treatment decisions. And we're going to have a little bit of a Q&A here with our guest. Be sure, if you're listening live, to give us some questions in the chat, and we'll be able to take some of those toward the end if we have time. Before we get started, I want to thank Lantheus Medical Imaging for sponsoring our program today. Now I'd like to introduce our guest, Dr. Tomasz Beer, joining us from Oregon Health and Science University, where he is a professor of medicine and Grover C. Bagby Endowed Chair for Prostate Cancer Research in the Division of Hematology and Medical Oncology. He leads the prostate cancer research program at OHSU. So thanks, Dr. Beer, for joining us today. I know it's early where you are.
It's my pleasure, Shelby. Good to be here with you.
Well, thanks. You're a good friend of Zero's on our medical advisory board. We tap into you a lot, so we always appreciate your insight. So let's begin. I mean, we know that all of the acronyms can be really confusing in prostate cancer, but especially with something so similar as PSA and PSMA. So if you could just shed some light on that, just to clarify any confusion for us. What are the differences between just PSA and PSMA?
Sure. So PSA, as we know, stands for prostate-specific antigen. It's actually something that is secreted. So it's a protein that's made by prostate cells and prostate cancer cells. It's not a prostate cancer marker, it's a prostate marker. And it is secreted both into the gland space in the prostate, but also into the bloodstream. So it circulates in the blood. It can be picked up with a blood test. And that's why we use PSA testing for early detection of prostate cancer, and also for monitoring of recurrence and disease response to treatment. PSMA, it has that crucial M in the name, that stands for membrane. It's prostate-specific membrane antigen. And if you remember your high school biology, we're all made up of cells. Our whole body, all the tissues in our body are a collection of cells. Each cell has a nucleus, a central piece, some cytoplasm, which is mostly liquid, and then a membrane. That membrane is the outer edge of the cell. And PSMA is this protein that is sitting there in the membrane in the cell surface. So what's important about that as a practical matter is it is not something that circulates in the blood. We don't measure PSMA blood tests, but it's anchored on the cell surface of prostate cancer cells, making it a really good target for imaging and for therapy. We can create molecules that attach to it, either antibodies or small, so-called small molecule binders, and then we can attach those molecules some sort of a contrast agent. That's what enables PSMA PET imaging.
Yeah, it's confusing, but I think when you break it down in that way, it becomes less so. So thank you. So we know that we saw some new PSMA PET imaging agents approved last year in 2021, and PYLARIFY was, of course, the first imaging agent available really across the country. So let's talk a little bit about where this tool, this diagnostic tool, fits within the prostate cancer, what we call the continuum, or the process or progression continuum, and really who should be thinking about PSMA PET imaging, what types of patients, and also when.
Sure. So first of all, I think it's important to mention that the reason this is an exciting new area in imaging is that PSMA PET imaging, or typically it's a PET CT, so PSMA PET CT imaging, where we combine a PET scan with a CAT scan, PET and CAT. You can remember that, no dog involved, just cat. It is more sensitive than conventional imaging studies. So we think about CAT scans or CT scans and bone scans as conventional imaging. And PSMA PET CT is more sensitive, which means it will show smaller prostate cancer spots and therefore detect spread of prostate cancer earlier. Right now, where it's been shown to be useful is in two situations. One is in folks who are newly diagnosed and have a suspicion of early metastatic spread, and when it's important to find that before making a definitive decision about surgery or radiation or combined modality treatment for newly diagnosed prostate cancer. And then people who have a rising PSA recurrence, typically after surgery or radiation, their PSMA PET imaging may reveal the sites of early spread that are otherwise invisible with conventional imaging. So that's where we're currently using these imaging studies. That's where they have an FDA indication. I think in the long term, we're going to see use in a broad range of areas. And one other area that is just very recently emerging is use as a tool to qualify people for PSMA-directed therapy. That's just beginning, but you're going to hear more about that down the line.
Great, thank you. So just let's go back to that question really quickly before we move on to the next. So, am I understanding you when you say this can also be used as really just a part of the staging process? So, a patient who appears with a PSA test and a digital rectal exam, perhaps, to have to need a biopsy and prostate cancer cells are detected, this could be used to continue that staging process and that diagnostic process?
Yes. So, and just to be clear, not everyone who's been diagnosed with prostate cancer really needs a scan like that. But in those patients who have higher risk features where we worry about early spread of disease, where the treatment decisions and planning might be different if we found that the cancer has escaped from the prostate. That's one situation where a high sensitivity scan like PSMA PET CT would be potentially useful.
Okay, thanks. So we wondered if you could shed some additional light on just really the availability of PSMA PET imaging. Can every patient get it regardless of where they're being seen or treated, or regardless of where they live in the United States?
So this is a relatively new technology. There are a couple of different agents available. The Polarify agent is approved for use throughout the United States. So that's the one that's available more broadly. This is a type of imaging that is done in nuclear medicine departments. So the same sort of facilities that do conventional bone scans. So at least theoretically, it can be offered in most nuclear medicine departments, at least those that offer other forms of PET scans. PET scans with other contrast agents, not this PSMA agent, have been around for a couple of decades at least, and are pretty widely available. So at most larger medical centers, there's the capability of offering a PSMA PET scan. You can look online, actually, I just did before this webinar, that if you just type into Google Polarify availability, very quickly you see a link that's provided by the manufacturer where you can type in your zip code. I typed in my zip code here in Oregon and noticed that there are 8 centers in the state of Oregon that have that available. So that's, we're a pretty small state, 4 million people. 8 centers is a pretty wide availability here in the state of Oregon. So I'm imagining that within a reasonable distance of where you are, this is available. It's pretty easy to find online.
Yeah, good. As I'm glad you did that. I did that a couple of days ago, and I think I saw like 750 imaging centers.
Yeah, it's it's almost everywhere. I would
Yeah,
think. I mean,
yeah,
certainly
no,
in enough
that's
locations. Yeah.
yeah, absolutely. Well, it's great news as far as just really access is
Yeah.
considered. We're always focusing on trying to get patients the latest and greatest when it comes to diagnostics and treatment. So
Yeah.
loving hearing that. Um, so, what are some of the really important things for patients to know about any PSMA PET imaging agent, but specifically Polarify maybe, but or just in general? What's the process like for a patient who's preparing to have this type of imaging?
Yeah, so it's pretty straightforward. For people who've had scans before, it's not all that different from other types of scans. Many of the scans we use, be it a CAT scan or a bone scan, involve getting an IV placed, an IV catheter, and then having an intravenous infusion of a contrast agent of some sort. For CAT scans, that's an iodine-based agent. For MRIs, that might be something called gadolinium. For bone scans, it's technetium. Yeah, and for PSMA PET CTs, it's the PSMA um, contrast agent. That's the secret sauce. So you get an IV, you get an infusion, and then you are placed in a lying down position in a PET CT scanner and roll through the scanner. It's not as scary as an MRI can be in terms of being a tiny tube that you have to sit in. It's a little more like a CAT scanner, and it's pretty straightforward. It's very much like some of the other scans that many of our listeners are used to.
Right. And from what I understand, and correct me if I'm wrong, you don't have to, no really restrictions. You don't have to, stop eating 12 hours before or reduce your, have restrictions on exercise, things like that.
Yeah, I don't think so. I will confess that as the ordering physician, I rely on my nuclear medicine colleagues to kind of give folks the detailed instructions. So I don't want to be 100% confident about that, but I don't recall any particular restrictions. But I would say that if you get a referral for this, you're going to get contacted by the department where the imaging is being performed, and usually along with that will come any instructions when and where to come, and
Yeah.
and if there's any minor restrictions, then you'll hear about those at that time. But generally speaking, this is a pretty straightforward process.
Excellent. Thank you. I think we at Zero hear a lot of questions really just about safety, and that doesn't just pertain to imaging agents, but certainly therapies and hormone therapies. But let's talk a little bit about just, is it safe? Yeah, that's really the question that it boils down to, that we hear the most often, I would say, at Zero.
Yeah, I mean, I think it's very similar to other imaging modalities. There's a little bit of radiation exposure, and that's obviously something that we want to be thoughtful about. But it's not a dose at which we would be concerned. It's not a dose at which we glow in the dark or have to avoid family members or anything like that. Um, and I think side effects are very, very uncommon. We've had since these imaging studies have become more available, we've had, I don't know, 30, 40, 50 people go through that, and I don't recall any significant side effects. So it's pretty similar to getting any other kind of imaging study where I suppose occasionally you might have a little bit of a reaction to the infusion, but nothing remarkable.
Great, thank you. So we talked a little bit before we went live on insurance coverage and what patients need to really just qualify for a PSMA scan. And while every insurance coverage is different, so I know we can't really answer that, but can you just talk generally about what patients need to do to qualify or to have a
Yeah.
PSMA PET scan?
Yeah, so first of all, one of my sort of practical experiences in the clinic is that when something new comes along, the insurance coverage typically lags a little bit, and it's just a matter of insurance companies catching up to the current standard. So, when PYLARIFY was first approved, we would not infrequently get an initial refusal, and the insurance company saying, "Well, we don't use PET scans in prostate cancer. Why are you ordering a PET scan?" And we'd have to go back to them with a letter and say, "Well, this is a PSMA PET scan. It's a little different. It's brand new. Look it up." And usually they would relent. Sometimes it would require the dreaded peer-to-peer conversation, which I can tell you your doctors really don't like, because you have to get on the phone and talk to somebody, and we're busy enough, but done a number of those as well. As the months go by, I think coverage is becoming much more routine. This is an FDA-approved imaging modality, and typically most insurance carriers would follow that FDA approval. What's important, I think, is having the right indication. So it's currently indicated for newly diagnosed patients with a suspicion of metastases or rising PSA. So for other situations that may not be funded by the insurance company. And it's important that your doctor or nurse practitioner or whoever you see documents that in the note. And that's not something you have to worry about, but if you run into trouble, it might be because the note didn't include the magic words, and they need to be added to the note for the insurance reviewer to see them. And then, typically you do need pre-approval, so it's something you want to be a little bit patient with, because you don't want to go get the scan and then get a surprise bill. Right. It typically takes a few days, but if the initial answer is no, it may take a little bit longer for the appeal. But almost all the time, we work our way through that process and get to a good outcome for our patients.
Yeah, that's wonderful. And I'll just provide a little Zero plug here for our comprehensive patient support program called 0360. The trained case managers who operate our 0360 program are very well versed in helping patients challenge, maybe that's a very kind word, approvals that patients really need to have the best care. So for anyone listening, if you're having that challenge, be sure to call 0360 and we can get you connected with a case manager to help you through that. So you have just someone else on your side and speaking for you and on behalf of you. And the case managers will jump on the phone with you and insurance companies to help tackle those situations together.
It's great to have those resources. And but I would also, see if your doctor's office can just take care of it for you first before you get it. Oftentimes we're able to handle that internally, so you don't have to worry about it.
Yeah, that's excellent. That's such great information to hear. So let's talk just really quickly about any medications or other conditions outside of prostate cancer that interact with any of these PSMA PET agents.
I don't think of medications that are an issue. I would say that folks need to be aware that PSMA, despite its name, is not entirely prostate specific. So we do see PSMA expression in salivary glands. So where the saliva is made, there's a little bit in the liver and a little bit in the intestinal tract. So if you're one of those folks who likes to look at your scans, don't worry, you don't have prostate cancer in your cheeks. That's salivary glands. So that's one of the things that I really think about in interpreting the imaging. You'll see some signal in the liver. In fact, one of the standards for a positive signal for prostate cancer is that it has to be brighter than what we see in the liver. So that's one of the things that that people need to be aware of. It's not that the name suggests it's all prostate, but it's a little bit more dispersed than that.
Excellent. Well, before we close, before we went live, we were discussing ASCO and a little bit on ASCO GU and really just what's coming down the pike. So, would you mind speaking for a moment on really just what oncologists and urologists are expecting with the future of imaging agents and really maybe just what the future holds? Look, if you had a crystal ball, what do you expect to see?
Well, I think it's not too difficult to imagine at least some of the things that we're going to anticipate. So this is an exciting new imaging modality, and we're just learning how to use it. The current indications are very narrow. It's really a one-time scan when there is a diagnostic question in a patient who's either newly diagnosed or has a PSA recurrence. We don't even have data on follow-up scans. Should we, if we see something, do we get a scan again in 3 months or 6 months or a year? What do we expect if that patient is treated? Does the scan get better all the time? Does it show a persistent signal? What about other uses? Can it replace conventional imaging? Do we really have to do a PSMA PET CT and a bone scan, or can we just do one of them? So I expect many, many efforts to better understand the performance of these scans, better understand how we might utilize them over time, how we might utilize them in other clinical scenarios with prostate cancer, more advanced disease, and so forth. And then, what are the limitations? No, we get excited about these new things in our field, and we should. These are useful, interesting, important new tools. But over time, we're going to learn some situations where they may fall short. They may miss something. So we need to understand that to be thoughtful about how we use the results. So we're gonna see those things too. Are all lesions PSMA expressing, or will we occasionally find some that are not? And in advanced disease, I can tell you that not every prostate cancer lesion has high PSMA expression, and we have to be thoughtful about how we can rely on the imaging. So there'll be a lot of studies and publications over the next 5 to 10 years. It took us a long time to figure out how to use bone scans and PET scans and CAT scans to our best advantage. And the same will be true for this imaging modality. The other thing I expect is that we're going to see more different PSMA contrast agents emerge. It's a very busy field. We're going to see treatments emerge that target PSMA. Those will be coupled to imaging, so we're going to need imaging along with treatment. So a busy field and a lot to do going forward.
Yeah, absolutely. Well, if you don't mind, we do have a couple of questions. I don't think I'll give you anything too tricky.
Okay, great.
But we do have some questions coming in from our live listeners. So one of our listeners is asking, try to make this as not as specific, maybe just to keep some of the patient information out, but really just curious about the PSA levels and at what point the PSA levels might indicate a PSMA scan should happen. And then is there if you know any information on where the PSA levels are running and whether or not one might get a false positive reading on an imaging scan using PSMA?
Yeah. So the early studies that enabled approval did look at particularly in the rising PSA situation, at the detection rates by PSA levels. And there's no question that the higher the PSA rate, the PSA level, the higher the proportion of patients have something detected on a PSMA PET scan. And so below a PSA of 0.2, we don't have a lot of data. And the detection rates would be expected to be quite low. And then they begin to go up from about 40% of patients to as many as 90% of patients when the PSA is above 3 or 5 or something like that. I'd have to look back at those data, but I would say point 2 for me is sort of a minimum level at which we would expect to detect something with any sort of a clinically meaningful rate. The issue of false positives is a little bit more difficult because it's not so easy to figure out that something was a false positive result, but it's a pretty specific agent. So as long as you understand where else PSMA is expressed in the normal organs, in general, most of the signals that we see are true positive signals. So I don't think that false positive signals are the biggest challenge for this particular scan.
Okay. Yeah, wonderful. Thank you. So you mentioned the point 2 PSA level. We have a patient who was mentioning that his recent PSA test showed point 0.1. So obviously that would be under what we're discussing. But at what point would that patient be able to consider this type of imaging, and maybe how long would that patient want to or need to wait for the next PSA test to indicate that it might be time to consider this option?
Well, it's really tough, of course, to give individual advice to a particular patient in a particular situation, but it really depends on uh, why we're getting the test. So if you're thinking about a patient with a rising PSA after surgery or radiation, which I'm going to assume that's what we're talking about here, the goal of the test would be to try to distinguish between a local recurrence and a PSA that's coming from early metastases or spread to distant locations. And if we find spread to distant locations, to try to distinguish between limited metastases, 1 or 2 or 3, and multiple. And that information can then be used to decide whether sometimes, for example, radiation treatment would be helpful. So we can use that to decide whether to radiate the prostate fossa after surgery, and at least on a semi-experimental basis to radiate limited metastatic disease. There's a lot of controversy about these approaches. The data are imperfect. We don't have survival studies, but that's how those imaging studies are used. So if one is at point 1, if there's been a consistent rise, if this is a patient who was at 0.02, then 0.04, then 0.06, then 0.08, now is at 0.1, and we have a pretty convincing consistent rise with an ultrasensitive PSA, you could consider an imaging study and recognize that it may not detect anything. But if it does, we could perhaps use that information. If, on the other hand, it's a 0.1 and it's just been sitting there, or if it's the first 0.1 and we don't have any other information to suggest this is a growing problem, that's a situation where I would, generally speaking, want to get more information, get more PSA data over time, and get a sense. Because at 0.1, it could just be a benign measurement that's not related to prostate cancer. But if we do undergo a scan at 0.1, we do have to recognize that the sensitivity is low, and the most likely outcome is that the scan won't show us anything. And it's not because there's nothing there, but it's just too early. So it's ends up being a very individual decision. Is it worth it to get a scan? Are we prepared to get a repeat scan, 6 or 12 months down the line if we see nothing? What's the story behind it, and why are we doing the scan?
Okay. Yeah, no, that's very helpful. Thank you. We have one final question for the morning. We have a patient here with advanced stage 4 disease, PSA that's rising. And he has been denied the PSMA PET scan due to not having a recent CT and bone scan. that showed progression. So he's wondering what would be the point of having these two seemingly lesser sensitive scans um, before or instead of just the PSMA PET that might be more sensitive.
Yeah. Well, this is a situation that illustrates sort of some of the vagaries of our health insurance and the rules that they adopt. Um, but like any medical test, I think the number one question would be, why are we getting the test? And while I'm a big fan of better imaging, and I think it can be important, not every clinical situation requires a particular test. So if someone has stage 4 disease, metastatic disease, uh, uh, what's important is to understand, is the disease responding to whatever treatment the patient's on or progressing? And that might be answerable with a combination of blood PSA testing and conventional imaging. And one may not need a PSMA PET imaging to answer that clinical question and make sound clinical management recommendations for that patient. Where a PSMA PET imaging test would be necessary is if one is contemplating PSMA-directed therapy on a clinical trial, or perhaps through recently approved, but not quite yet available in most places, therapeutics. So just because something is really new and exciting doesn't mean you always need it. And I think I would go back to one's physician and think about, what clinical question are we trying to answer, and then decide if a test like this is really necessary and will make a clinical difference. Because at the end of the day, it's not about medical tests; it's about living as long and as healthy as possible. Not every situation demands a particular test, and not every time we get a test does it help us take better care of patients. So that's how I would think about it.
Yeah, no, very good point. Thank you. Well, we are now at our time to start wrapping up. So thanks again, Dr. Beer. We always love chatting with you. I love chatting with you. I always learn so much. I know our patients and our Zero community does as well. So thanks for being here, Dr. Beer.
Thank you, Shelby. It's a pleasure to be with everyone today.
Great. So thank you. Thank you again to Lantheus Medical Imaging for sponsoring our Facebook Live today. If you want to learn more about PSMA PET imaging for prostate cancer, or about all of Zero's patient programs, one of which I mentioned earlier, or learn of ways to get involved, receive help, please visit us at our website at zerocancer.org. You're also welcome to email me directly, shelby@zerocancer.org. The Zero team is here for you if you have questions. So thank you again. Have a wonderful Thursday, and we'll see you all soon. Bye-bye.